the summary of my topic is what is anatomy, what is inside both male and female, what is the things which are having the urinary control in both the male and female, and what is the continence mechanism, what is the urine control mechanism which is there in males and females, and what are the types of urinary incontinence, what are the types of urinary leaks which we see commonly in our OPD, both in males and females. Then I'll touch on post-prostatectomy after removing our prostate, what are the incontinence and how to deal with it. So in males we have a bladder here, and you have a very long urethra which is there inside the penis. In males we have prostate gland, which is unique to only males. It is not there in females. The main part of the prostate gland is to get the urinary control and also to secrete semen, which helps in initial reproductive part of life. So this is not there in females, which is there in only males. Whereas in females, they have a very short urine passage, only 4 centimeters, where in males it is 25 centimeters long. So they doesn't have any prostate, or they doesn't have any semen or secreting things anywhere in the urine passage. And they have a supporting structures like uterus, which is there below the bladder, which gives lot of support to the pelvic organs like rectum and urine passage below. So when in some females, when they remove hysterectomy, when they undergo removal of uterus, then they'll start feeling some urine leak or motion will leak or something will happen, because uterus is such a supportive structure in pelvic organ. So once we remove the uterus, all this area, the bladder area and the rectal area will become weak, and they can have some leakage in the urine or the motion area. So we all know the kidneys are the main important structures which will secrete urine into the bladder. So all the blood which is coming into the kidney gets filtrated by the small things called nephrons. And apart from producing urine, it also has a lot of other functions like increasing your hemoglobin, in metabolism of vitamin D, which is you're checking in the master checkup. All these things which happen in the kidney only. Apart from filtration function, which gives us urine, the kidney also does all this, increasing your hemoglobin, vitamin D, and electrolyte balance, everything it maintains. So from the kidneys, the urine will come into the urine passages. These are the small tubes which connects the kidney to the bladder. These are called as ureter. Once drop by drop, and the urine comes into the bladder, the bladder is the structure which will store the urine, hold the urine, and pass the urine. So it's such a critical important organ. So if urine is there inside the bladder, it has to be stored in some amount of pressure. If any cough, say if I cough, or if I lift any weight, or if I do any sort of thing suddenly, it will increase my abdominal pressure. Because I am contracting my abdominal muscles. When the abdominal muscles are contracted, ultimately it will fall inside the bladder, which is holding the urine. But all the patient doesn't leak urine. I am not taking urine and weight or anything, because bladder is such a critical and important organ which will maintain some pressure. That pressure exceeds the pressure of the abdominal pressure. That's why we don't leak. So whenever this pressure is coming down, particularly like post-surgery after removing the prostate because of the muscle weakness, or when they remove hysterectomy, when they remove the uterus, that muscle, that layer is becoming weak. Because of that, this pressure comes down and it is below the abdominal pressure. So whenever the abdominal pressure increases, they have a leak. This type of leak is called a stress urinary leak. Stress is nothing but the weight lifting, what are the activities you do, you cough, you sneeze, you laugh. All these are stress to the bladder. So whenever the stress is happening, it becomes the leak will happen. So we all know that whenever we want to go to the restroom, whenever we want to pass urine only, we can pass, it's in our control. So this control is very important because it has a lot of important structure which is there in the spinal cord and the brain, which will help to control this entire mechanism. So initially what happens is bladder will store urine. Bladder will expand. This expansion causes some sensor. You have all these sensors. When you enter lift, the doors are getting open. Even the bladder also, there are sensors. Whenever the bladder is getting filled, say 300 ml, 350 ml of urine is there inside the bladder. So the bladder will stretch. The stretch will cause some impulses go from the bladder to the spinal cord. From the spinal cord it goes to the pons. Pons is an important structure in the brain. From there the reflex will come back, which will help the patient or us to understand, okay, our bladder is filled, we need to go to the restroom. When you walk to the restroom, this continence mechanism, the control mechanism is always active. It is not making you leak urine or pass urine anywhere during the walking to the restroom. It is intact. When you go to the restroom and try to stand in front of the lavatory and pass urine, so there is a sensory impulse which comes back to the bladder area from the spinal cord, which will relax the sphincter. So basically, urine controlled by two sphincters. One is called as the internal sphincter, which is close to the bladder here. The other is called as the external sphincter. The blue color one which is going here is called as the internal sphincter. And the red color line which goes into this muscle is called as the external sphincter. So where does our prostate lie? Our prostate lies between the internal sphincter and external sphincter. This small gap here. So in this small gap our prostate lies. So it is such a critical and important structure which is there in between this mechanism. So it is close to the internal mechanism, it is close to the external mechanism. So whenever we remove the prostate, that's why there will always be some incontinence at the beginning. So once we strengthen that muscle, the muscle which is nothing but the external sphincter, which is a voluntary muscle. If you want to go to the restroom and you stand in front of lavatory, when you relax, when you give your command, this muscle gets relaxed. We don't know this mechanism, but this is the muscle which gets relaxed and patient will be passed urine. So this is under our control. The internal sphincter, which is there next to the bladder, which is above the prostate, this is not under our control. This is in the brain control. So whenever you go to the restroom, the detrusor muscle, which is filled with your bladder is filled with urine. So this muscle will try to push the urine out, and this sphincter, this internal sphincter will relax, the gates will get opened, then the urine will enter into this passage. And when you go to the restroom and try to be relaxed and you want to pass now, so this mechanism also will open, the second gate also will be opened, and finally you pass urine. So this is how the urine is getting controlled. So coming to the continence mechanism in males, so I told you this is the mechanism, the prostate is lying in between the two mechanisms. One is the bladder neck mechanism, nothing but the internal sphincter, and one is the external sphincter. So this is the external sphincter. So the prostate lies between the internal and external sphincters. So whereas in female doesn't have any prostate, they don't have any prostate, but they have very short urethra. It's only 4 centimeters. It's very short. As soon as we go inside, you see the bladder, there won't be any prostate or any. So they also have two mechanisms. They also have internal sphincters, which is not under their control. The other one is the muscles, which wrap around it. This is the urine passage of the females. There are muscles which wrap around this urine tube. These are called as the external sphincters. You can see the wrapping here. So these are called the external sphincters. Whenever there is any baby delivery, say after delivery, or whenever there is any hysterectomy or something, this muscle will get loose. This muscle will become loose. So immediately after delivery, they will have some amount of urinary leak. When they have any stress or any laughing or sneezing, when they walk, they will have urinary leak, because this muscle gets weak. So these two sphincters, which are very important. So coming to the types of incontinence. So what are the types of? What you are experiencing because of post-surgery is called as stress urinary incontinence. Apart from the stress urinary incontinence, there are a lot of other incontinence called urge incontinence. That means you have urge to pass urine. You got a urge to pass urine, but while you are getting up and going to the restroom, before leaving the restroom itself, you are passing urine inside your pants. That is called as urge incontinence. One is combined. So this happens in females where they have both urge incontinence, that is, they want to go to the restroom before itself they are passing, and then they have also stress urinary incontinence. When they laugh or sneeze, they have some leakage of urine. That is called as combined or mixed incontinence. The other thing is overflow incontinence. Overflow incontinence is nothing but if your prostate problem is there, prostate got enlarged, and you don't have any cancer. So some people, what happens is you cannot pass urine. They'll have a lot of urine inside the bladder, and that urine will get spilled into the urine system. Whenever he walks or sneezes or something, some leak will be happening because already bladder is full, 800 ml is there inside. So the bladder cannot accommodate more urine, and they pass this urine in dribbles. So it feels that they are passing, they are having incontinence, but when you examine them, the bladder is full, they are in retention. So what is called overflow, tank full, tank meaning moving the water. When you are trying to pump the water inside the tank will overflow. So the same thing will happen. So that is called as overflow incontinence. The other thing is called as functional or social incontinence. These are commonly in dementia patients, other psychological abnormalities. They try to pass urine in social activities or functional activities. It is not the problem in the urine passage or in the bladder. It's a functional abnormality, particularly happens in psychiatric and dementia patients. So why it is so important? Because it also has some impact. It has a dose efficiency. If you want to go somewhere, you will think about twice whether to go there or not, because you feel that there is some foul smelling smell can come to the next person who is sitting next to you. So you feel a lot of embarrassment. It increases the ability to be independent. You need to be with someone or to have some social support, to have your wife or someone with you. So it always has some psychosocial impact. So it causes some anxiety, poor quality of life. So all these things are there when you have these incontinence problems. So I told you about disease, stress, urgency, mixed and overflow incontinence. So why it happens? Coming to urgency incontinence, most common things in urgency is bladder is absolutely normal. Your continence mechanism is also absolutely normal, which will be able to control the urine. But the bladder layer is inflamed because of some infection or some radiation, or because of some other problems. The bladder layer is inflamed. It is not able to store more urine. With small amount of urine itself, you are having a strong urge to pass urine, which you are not able to control before going to the restroom. So which most commonly happens in infections. So infections, cystitis, radiation, in some cases Parkinson's disease. So all these people will have some amount of urge. The bladder is not able to store good amount of urine. With 150 to 200 ml itself, it is having a strong urge and trying to push the urine out. So it happens in these infections or the radiation. You all undergone surgery for the prostate. Some people who was given the radiation as a choice, and when they have radiation, they can have the surge incontinence, they can have blood in the urine. So because of the radiation, the bladder epithelium is so sensitized that it cannot store much urine. It will try to push the urine with 150 to 200 ml to transport the urine. So those type of people we try to treat with antibiotics. Even females also, when they have urinary infection, when they come to OPD, their main problem is adequately poor sir. They are going frequently. Night time and 5 to 6 times I am passing urine. Why? Because it is an urgent incontinence infection, which is causing the bladder not to store much amount of urine. So we give antibiotics. Some people who are not having any urinary infection, there are medicines which will help to control the bladder not to push the urine out. So overflow incontinence, as I told you, it is because of the blockage. Blockage because of most common is prostate enlargement, which is causing blockage. We put catheter temporarily and we try to treat the prostate. If there is no cancer, we do some endoscopy procedure to relieve the blockage. So coming to the stress incontinence, most common is multiple vaginal deliveries in females and old age because of the weakness of the pelvic floor muscles, and urological surgeries like prostatectomy, which we have undergone. All this can cause this testicular incontinence. And what are the managements we have? One is pelvic floor muscle therapy, that is nothing but Kegel exercise which you have been taught. The other things are sling surgeries. Sling surgeries, I will explain to you what are the sling surgeries. The other options is artificial sphincter. That also will explain to you what are how it is done. So coming to the post-prostatectomy incontinence, as I told you, the prostate is there in between the bladder neck, that is internal sphincter and external sphincter above and below. So such a critical structure is a small space between the mechanisms. So whenever we do a prostatectomy, we want to achieve 5 outcomes. This is called as pentafecta, 5 outcomes. Pentafactor is nothing but how your oncologically, cancer-wise, how good is your control, and functional, how good is your continence, and if you are able to have some good erections before, whether we can able to sustain that erections by preserving some nerves or not. So the five options are called as pentafactor, which is nothing but cancer control. That is the first and preliminary thing which we always try to achieve. Then comes urinary continence. We try to preserve good urine passage length inside when we do anastomosis. When we try to join the bladder to the urine passage again, the inside we want to preserve the good urine length, the tube length, so that you will have this good mechanism. So your urine control will be restored within 3 months to 5 months. The other thing is potency, whether you are able to have some erections or not. This we can achieve by sparing some nerves. It depends upon what risk category you comes under, whether you comes under low risk or high risk. Depending upon that, we can do some nerve sparing or non-nerve sparing, depending upon your erections before surgery. The other thing is margins. When you all know, when you come for the urine bag removal, we always explain how is your continence to be, how much exercise you need to do, and we always explain about the margins and everything, because margins will define how is your PSA or cancer control. And post-operative, you should not have any complications. You should go home without any complications. So all these things are called as pentafactor. All these things, the most important thing is cancer control. Next only comes a urinary control and everything. So how to assess continence? It is very difficult. For me, when I talk to you, I don't know whether I am assessing correctly or not, because it's very subjective, it's very variable. Some people it may be a mild continence, some people it can be they can feel that it is a lot of amount of urine is leaking, so it is very subjective. It varies to patient to patient, patient to patient. So it is difficult to arrive with a common definition how to assess the continence. What we commonly assess is how many pads that you are using per day, how many pads you are using. That also is there some subjective. Some people can have a small quantity of urine leak, but they say the pad is full and they would have changed the pad and they can say I'm using 3 pads per day. Probably their actual usage is 1 or 2 pads. So it is very difficult to assess how is your continence, how is your incontinence. So how we assess is like after removing the catheter, we assess you after 6 weeks from surgery. After 3 months from the surgery, again 6 months from the surgery, then after 1 year we assess you and we see how many pads you are using, decreasing every 3 weeks. So our thing is every 3 weeks your one diaper should come down. So at the end of your 3 months to 5 months, you should be with one diaper. That too when you need to wear when you are going occasionally outside for a function or something. But indoor when you are walking in the house and you are doing your direct activities, you will not be using anything. But fear of having some leak when you go outside like OP visits or when you go to some marriage, one diaper, that is not a severe leak or anything. So this is how the other way of assessing is weighing the pad. So your pads are getting leaked. After 5 months, you are using 2 pads per day. So I need to see how much pad is getting wet. So we need to measure the pad or the weight without the dry new pad weight in a weighing machine. And when you discard the urine diaper, again weigh it, subtract it from the previous weight. So that much amount of urine is leaked. Say 100 grams or 200 grams extra. That means 200 ml urine is leaked. So that's how we assess by measuring the pad weight. So what are the patient factors? So surgically we will try to achieve the good urine length and everything, but patients also having some factors. Say if patients, there are some studies which were done some years back, which were published. So they say when they do the surgery for patients who are younger group, that is patients who are 66 years to 69 years, and they compare the patients who are more than 70 years. So when they compare this age group, patients who are young, they attain continence, they attain urine control much better than patients who are little older. So that is one study which was done. So all these are patient factors. Why all patients are not same? And patients who are little obese patients. All the obese patients also, when compared to normal non-obese patients, they have a higher probability of urinary leak in 1 year. So this is the study which came out. So even in high volume centers, say this one center in Germany, they have a marketing clinic, they do the maximum number of prostates in one center. So they published a 4-year study, 2008 to 2012, they did around 8,573 patients of post-prostate surgery. For them itself, the continence outcome at 12 months is 89% and 24 months is 91%. So there are some set of patients who cannot attain continence, or there is some set of patients who will be on more than one diaper. So there will be somewhere around 5 to 8% of the population when we do 100 cases. So how we manage? So whenever after you are coming for catheter removal, after removing the catheter, we always need to the steps how we are going to progress. So we need to individually tailor these patients. So how much severe is the problem? How many pads they are using? If there is a regular continence, is because of some infection is there, that's why because of infection is having some mild incontinence, or it is a genuine stress-urinary incontinence we need to do. And how much effective it is disturbing the quality of life of the patient, and what are the patient expectations, what he wants, how much pads he was expecting to come down, how much pads if he comes down he will be happy. We should talk about, we need to talk to you to find out what are your expectations, and with the least amount of intervention you can get a maximum benefit or not, we can tell you. So whenever any patient after 3 months or 5 months, if still if he complains of some urinary leak, so we always assess whether he is having some urinary infection or not. That is the first thing. We'll send for urine culture, we see if there is any urinary infection. If the urinary infection is there, we treat the urinary infection. Because urinary infection can cause some urge incontinence, which you can interpret as some stress. So urge is different, stress is different. So urge is when you have that sensation to pass urine before going to the restroom, the urine is leaking. Stress is without your control, it is leaking. So both are different. So we need to rule out urinary infection whenever a patient comes after 5 months, still on Kegel exercise, complaining of urinary leak, we do the urine culture, we assess his urine speed and flow, and after passing urine, how much is left behind inside the bladder, all things we assess. And we start on if there is no infection. If there is no infection and the urine speed is also good, only thing is having genuine stress leak because of cough or something is still leaking, then we Kegel exercise is the first thing which we advise the patient. So the problem with the Kegel exercise is when you do the Kegel exercise, me or someone next to you cannot know that you are doing correctly or not. It is very difficult to identify whether you are doing the correct muscle contraction or not. So it is very difficult to stress upon the patient to identify the correct muscle and do it properly. Especially people who come from the village or a little bit old patients, they are very difficult to understand what we are trying to tell them, what muscle we are trying to tell them to contract. So at the end of 3 months, they'll be contracting their thigh muscles or buttock muscles and they still complain of some urine leak. You understand? So it is very difficult to tell what time, which muscle we are expected to contract. So further we have biofeedback. I don't know how many of you has undergone Jogo physiotherapy. Can you raise your hands? Jogo physiotherapy. So nobody. So Jogo is one company which will give a biofeedback mechanism. Nothing but when you take an ECG, they attach small leads wire to your chest and take an ECG. So same way they attach small wires to the perineum below the scrotum. They attach the small wires like the ECG and they'll see what muscle you are contracting. Whether you are contracting the same muscle or you are contracting a different muscle. So they will show it to you. It will be like a small iPad. So they'll show you the iPad and they'll ask you to contract. Each time when you contract, there will be a wave coming. So they'll tell you, yes, this is the muscle, this is the muscle. Then they'll train you with some sessions. So, come. So they'll train you with some sessions and understand you and teach you what muscle exactly to contract. So apart from the Kegel exercise and biofeedback, there are some medications which are not having any strong recommendations because it's a physical weakening, the muscle. The medication will not give you strength to that muscle. But there are some medications like relaxation and imipramine which we commonly use in post-prostatectomy incontinence. In some people they work well, in some people they will not work well. So it is not having a good recommendation to take this medicine. surgery is always considered as the last option. I'll tell you what are the options in surgery also. So you all know legal exercise, how to do. So the main thing is you need to empty your bladder, start strengthening your pelvic floor muscles. You need to count from 1 to 5 initially and try to extend that number up to 8 or 10. Contraction of 5 to 8 seconds and relaxation of 5 to 8 seconds. So this is important. Each one contraction and relaxation is considered as one exercise. And you need to do at least 80 to 100 in first 2 weeks, and slowly you will increase to 300 exercises per day in coming months. So this is very important. It has to be done regularly, which you can do by sitting or sleeping, by any posture you can do. So very important exercise. Even in females also who is having urinary leak, you can start doing this Kegel exercise. No money, you're not spending any money on medicines or anything. It's coming free of cost. You can undergo. You can see the results within 3 months. Within 3 months, that stress leak, when you cough or sneeze, some urine is getting leaked, 10 ml or 5 ml. That also will get controlled when you start doing this Kegel exercise. And the other thing, what we recommend to the patients is pin and clamp. Some people who are coming outside still having some urinary leak, this is the most least invasive and less expensive way of controlling the urinary leak. It is called a pin and clamp, which we give it to the patient. Which is a small device which costs around 250 to 350 rupees. It consists of a sponge inside and has a clipping mechanism. You just need to open the clip after going to the restroom. This clip will unclap. You will pass the urine. After completing the urine passage, again you can just lock it. It will be inside your underwear. You cannot be seen anywhere. So this is one thing, but the problem with this is it is a little painful, and you feel you after 6 months or 1 year you feel you want to have a better thing than this. So it is like a temporary thing when you are practicing Kegel exercise, which is a good alternative when you are not want to go to extensive surgery or something. So there are other things called as bulking agents. Bulking agents are nothing but these are the semi-solid liquid material which we inject inside the urine passage. You can see these small white spots. So what we do is we do endoscopy. We put the camera inside the urine passage with the help of the needle. We inject some bulking agent. Bulking agent is it's a liquid form. Once we inject inside the tissue, it will form it goes into a solid state which will help to block the urine passage. So physically, when putting some barrier or some gate to block the stress continence. So this is called as bulking agent. Now artificially it is bulking the tissue by injecting something below it so that it will bulk and cause urine blockage so that the stress leak will be coming down. So these are injectable devices which we use to put injections, but it's very expensive. The advantage is it is easy to perform minimum mortality by doing endoscopically or by periapital also we can do in females, and it doesn't burn any pressure. If you want to undergo any surgery in the future also, it is not going to be any inconvenience during the procedure, but you want to go with a bigger procedure. The disadvantage is it is very expensive and it is not durable. So whatever the injection material which is going inside will again liquefy, or it may not act to a correct pressure where it can block the urine. Sometimes it can overblock and cause complete urine blockage where you require some catheter. So it is very expensive, not durable, may require a medical procedure, and it is not that much effective. So by looking at the picture and everything looks promising, but when you do it to the patient, it has only 39 to 49% of confidence rates. So who will be ideal candidate who are using pads more than 3? No previous history of any radiation, having a good urethral ring passage, and patients who are okay with multiple sessions or who are happy with this procedure, we tend to give this thing and they will be on that bulking agent therapy for a long time. The other thing is sling. So the whole idea is, after removing the prostate, so there is no prostate, this area is becoming weak, it doesn't have any support. So to create some support, we give artificial support by lifting that area. We lift the urine passage by creating some artificial lifting by mesh. You all know when we do hernia procedure, they'll put mesh. So same mesh or same tape is like a tape or mesh which we use to lift this area and sling it above your bone. You have a pelvic bone, no? So we use two slings, lift that area up and put it above, which are completely internally, you won't see anything outside. So which will give some support to that area and causes, which will prevent some incontinence. This is called as sling procedures. The other thing is called as artificial urinary sphincter. This is very expensive. So it has a device consisting of three parts. One is a pump, one is a reservoir, one is an inflatable cuff. So this inflatable cuff, we stitch it to the urine passage. This urine tube we put the inflatable cuff. And this cuff is having connection to both the reservoir and also a pump. So initially it came in 1979 and still now this is the gold standard when a patient comes with a severe incontinence. Severe incontinence is like using more than 5 pads or 4 pads a day or 3 pads a day, who is not able to control by doing Kegel exercises, or patients who is given radiation. After surgery, some patient who requires radiation, after radiation, the area in that entire tissue will lose its vitality. The mechanism of support will come down. So those patients, even if you do Kegel exercise also, it won't help them much. So those patients require some additional support, that is by sphincter. So this cuff will be attached to the urine passages. Whenever patient wants to pass urine, always this cuff will be inflated. So always it will be inflated, so always it will drop the urine. So in normal times it will drop the urine by this button which is attached in the scrotum next to the testis. When you press this button, suddenly this cuff will get deflated and this will go into the reservoir and the urine passage will become widened and you will pass urine. It will give you 3 minutes to 5 minutes of time. So after the 3 minutes or 5 minutes, automatically it will inflate again. So in this 3 to 5 minutes, you need to pass urine. Automatically it will pass in 3 to 5 minutes. You will empty your bladder. So this is one of the modality where we use commonly in severe incontinence, where this patient who are using more than 3 to 4 pads per day. And there are some foods, I know you commonly ask what are the foods to be avoided. So all alcoholic beverages which contains carbonated drinks, artificial sweeteners, chocolate, spicy food, coffee, tea and vinegar, all these things should be avoided because all these things can cause some urgency. Urgency invariably causes some leak. So all these things need to be avoided to control your urinary urgency. So finally the overview, the initial steps are Kegel exercise and biofeedback mechanism. In some cases, they will require some medications which will control the bladder spasms and not to control to hold more amount of urine. In extreme cases, where some patients will require the sling or artificial urinary sphincters. Thank you.